Thank you, Joe, and thank you to Venky for the kind invitation. This is not going to be near as high-tech as what we just saw, but it's kind of what we're doing now in 2025, 2026. And looking at specifically, asked me to talk about the Nexus graft, and we were fortunate to be some of the phase 2 investigators for this. So I think this is a graft that really is going to kind of help us as we move forward to some of these selected patients that I think are going to be best served by endograft therapy. It's really a two-component graft. I don't know how many people have had experience with it or not. But basically, the main component is this component here, which you'll have unlike other technologies, this actually goes up into the innominate. So as you guide it in, it goes up the innominate, and then you have a very large portal for the ascending, and then you have a second component, which is your ascending graft, and then you, of course, can build further down to the descending thoracic aorta after you've implanted the main graft going in. They have pretty much shaped catheters to assist with this as you're doing it. And again, the main concept is you're going from the groin up and then out through the arm and through the innominate for the graft itself. So a lot less manipulation of trying to cannulate gates and everything, because if you can't go through that large ascending aorta, you should not be doing this procedure. And so here it comes in, just looking at the different steps as you go through. The catheter goes in, you start deploying it, there's the ascending gate there, then you're going to have it deployed all the way down. You do the ascending component here, and then you can balloon it at the completion of your procedure. And then you have to have a carotid subclavian bypass in there as a single branch graft. Now they have duo and tray, which we'll talk about towards the end. The original trial was for aneurysms, dissections, and PAU-IMH, but the majority of them were in the dissection group for the original trial, and the trial is now completed, and that's being submitted to the FDA. 31 centers, 30 of them in the United States. Here's a typical case, someone coming in, 65 years old, he's had a dissection going down, and he's developed a arch aneurysm involving the subclavian. But the dissection was treated with a graft. Here you can see there's the dissection coming in, and then you have it going in with a large aneurysm right at the level of the subclavian, so the visceral branches. Here's going in again, as I showed you in real time, that the graft goes in. You'll come in, you'll identify the takeoff of the carotid. You then deploy it in a fairly rapid fashion to the first two wire forms here. That's where you get to the point where you really need to move along. You then deploy the graft with this is the most scary part, you do a little forward push on it, or big push as they call it, and then you deploy the rest of the graft coming down. You're rapidly pacing generally at this time, and then you can come in and through this nice big opening, you'll come in and put your ascending graft in there. You can balloon, and again, we'll do a rapid pacing for some of the more critical components of this, but you're not doing a lot of great vessel manipulation, just getting it in the innominate as you go through. So I think that's one of the real advantages is we're trying to help decrease the overall risk of stroke when you're doing these type of procedures. And there's the ascending graft being deployed, and that kind of completes it. And then you'll balloon into the innominate. And then if you need to, we don't always do it, you can balloon the junction of the ascending. And so that's there, and then the completion, I won't go make you see this, but you can see the whole graft comes in, they put a distal component down here, and then the ascending going up. Obviously, if you have someone that has a bovine arch, you have to make sure you bypass the carotid because you're not going to have enough landing zone. I've had it where I've had dissections going up in the innominate, and I had to go up into the carotid, and we just made sure I stayed below the carotid bypass as you go in. So what are the data? That's really what we're here for. And basically what we saw is that it's kind of the usual patients with dissections and atherosclerotic disease coming in. There's one thing I will say, there's a high incidence of coronary disease, prior sternotomy. I think it's something that we all consider as, if you're looking to do an arch repair, that's a little bit more challenging. We'll discuss that later. And a history of aortic intervention in almost 60% of the patients that were in the trial. Again, had very low incidence complications of bleeding, no device occlusions. Total failure to exclude the primary entry tear was 0. New dissection requiring intervention was 2 patients at 30 days, and then 1 patient had residual that had to have an ascending repair. Lesion-related mortality. This is, again, this is the high number here at 6.4%. and then you go in, renal failure was 0, paraplegia was 1 patient, but that was not persistent. And then coming in, stroke is obviously the biggest thing we're worrying about in these patients. Disabling stroke at 1 month was 7, which is 7.4%, but they all but one of them recovered going out. Well, 5 of the 6 recovered going out. 1 patient died. It was one of the device-related complications, but the majority of those patients that had initial stroke did in fact recover. Again, going out 1%. Hemorrhagic stroke was 3% within 30 days, and thromboembolic was 3%. And then endoleaks was very low as you went through. Type 1B was one patient at 30 days, which was strict with extension of the graft, and no other major endoleaks. They did have some type 2, which did not require further intervention. So Nexus is a specific design to treat the aortic arch going into zone 0. It's for the high-risk surgical cohort. Every patient we did a Nexus on, we worked in conjunction with our cardiothoracic colleagues, and they had said they were not a candidate for open repair. So I think this is critical when you start going into this. It has to be a communication, and we actually had our cardiothoracic surgeon scrub in with us while we're doing the actual Nexus procedure. So I think that collaboration is key as you start doing it. We had low rates of endoleak and aortic-related complications. So I think this is certainly something with the 1-year data looks good. It's now in the hands of the FDA, and we'll get their final decision hopefully within the next 90 days. So what's the next generation coming out? Well, 1's good, is 2 or 3 better. And so this is where you see, obviously, take the worst possible picture to put the complications. So this is somebody with a neck hematoma after the carotid bypass, so that's always a concern. I tend to do my carotids retropharyngally. I do not like using externally supported because I think they have more swallowing issues and everything else. And I use Dacron grafts for the retropharyngeal carotid. And then I reimplant, or carotid subclavian, reimplant the left carotid into the graft. Here's again, one of the problems with one of my cases, it had an ascending repair that had a very significant bird's beaking coming down here where you really had to negotiate and come down here, but then you were very close to the coronaries as you come in. I think this is one of the problems we're seeing is there's only one Dr. Joe Caselli out there doing this, and a lot of times we end up with patients that get these little bitty ascending grafts there for type A dissection, and then we're suddenly having to deal with that where they don't do a hemi-arch or anything or a frozen elephant trunk. So I think there's a lot of people out there that may not be doing optimal surgery for that initial type A dissection, and this is something we can come back and use to help fix them long-term as it goes forward. Here's an example where this is the duo, where you come in and they'll actually come in. There's a higher stroke rate associated with duo, but the main thing about it is it does allow you to come in and then go in and put grafts into the innominate as well as the left carotid. Then all you have to do is a carotid subclavian bypass. So you're not having to do the carotid and all the concern there. And here's an example of the CT scan of the person that got one of the duo in Europe. And you can see an aneurysm going down. Here's the images there, and again, you come in, you're going up into the innominate. This same thing as the big push will go through, and you've seen that where it's deployed, the first 2 wire forms in the innominate, then they come in and they deploy down, the big push coming in, and the main thing is I can't skip further down, but you'll see as we come back in, there is a portal here, so you have it's wired already, and then once you've gotten the graft in here, you'll be able to come back in and go through that portal right here, and you go up into the left carotid, and that's where you can put your secondary stent going into the left carotid. So now you've done a nominate left carotid, and all you have to do is a carotid subclavian if you deem it needs to be done. And obviously you can extend down into the descending thoracic aorta as well as you have to put the ascending piece in if needed. So I think that's the next step, but we have to keep worried about the stroke rate with more manipulation. And the post-op study showed that it totally excluded the aneurysm, and both portals were patent. Okay, and then finally, Trey, if 1's good, 2's okay, now is 3 better? And this is their now ongoing study now going in Europe, and they're looking at using the Trey. Their initial study, they come in, they've done 22 patients. They said the primary endpoint was reached in 96% of those cases with technical success. no mortality, but they have 9% neurologic events. So I think, in my mind, that every time you keep adding more cerebral vascular manipulation, your risk of stroke tends to go up. And that's what we saw with some of the earlier devices that weren't Nexus, that they did have a higher rate of stroke. And that's really what kind of stymied them as they went on for development and acceptance. Endoleaks, they had, it was mainly a type 2 endoleak, as I mentioned here, with the 3 cases. And this is the trio graft. I think it certainly is going to give us all 3 vessels cannulated, no need for X-ray anatomic bypass. You have an integrated system going to the brachiocephalus, so that's protected, but then you have to deal with the subclavian and the right or left carotid. And finally, this is the 3rd graft, and that's still under evaluation. They're going to be starting the Duo trial probably as soon as they get approval for the Nexus single branch graft, and so that'll be coming here. Treo, I think, will be a couple years down the road yet. So thank you for your attention. I look forward to our discussion.